There we go. And we are just recording the session today, which is mostly presentation based. We will not be recording tomorrow's session, which is discussion based. So I want to thank everyone for making the time to come to this event, which has been generously funded by Michael Smith Health Research BC and organized by the Peer Models Network, which is an initiative led by Dr. Mohsen Sadasafavi and his team at UBC Faculty of Pharmaceutical Sciences. One of the goals of the Peer Models Network is to increase communication around how scientific models are being used to inform healthcare decision-making and how that should look going forward in the future. The focus of this event is on health economic models, which are the type of models that are used to study potential costs and benefits of different ways of providing healthcare. Health economic models affect everyone in BC, including patients, members of the public, by influencing how health services are funded and delivered in the province. So today we have participants from a number of different settings, including members of patient and public organizations, researchers, and decision makers. And the goal for this event is to start a conversation around how health economic models can best reflect patient and public values, taking into account new ideas around patient and public involvement and transparency in modeling in particular. So as I think most of you know, our event has two parts. Today, we're going to be hearing from three excellent speakers who will highlight different ideas relevant to health economics and values and transparency in modeling. And tomorrow, we're going to have a facilitated discussion. So that will give everyone an opportunity to draw out points of interest for the group, as well as identifying research priorities and thinking about other ideas that can come out of these conversations. So today the format will be that each of our speakers will speak for about 25 minutes approximately. And then we'll have a chance at the end of each speaker to have just some clarifying questions. So not really moving into an open discussion, but if there was something that the speaker said that you didn't understand or you wanted to just clarify, there'll be an opportunity to do that following each speaker. And then tomorrow, we'll have the full 2 hours for conversation, so completely interactive format. So if you have things you want to say or ideas you want to expand upon, maybe make some notes so you don't forget those thoughts for the discussion tomorrow. And at both of these events, we're really fortunate to have Sam Brad doing some graphic recording, which he'll be sharing throughout the session. So Sam, do you want to just say a quick hi to everyone?
Hi, everyone. I'm Sam, and I'm the graphic recorder for the session, calling in today from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh. And my role is to listen deeply and then to draw what's happening. And so what you'll see is this camera here will become the illustration. And if you would like to follow along, you can pin it in Zoom, but don't worry if you want to just focus on the speakers, we will be showing the illustrations at the end of the session as well. Thanks, Trilby.
Great, thank you so much, Sam. And so for today, I would just ask that if you do have questions for the speakers, that you hold them till the end of each speaker. And then we will take questions either through the chat or by having folks raise their hands. And finally, I just want to mention that we do have some tech support available today from Kat Zimmerman. And Kat just has put her number in the chat. So if something happens and you get disconnected from the Zoom and you can't figure out how to get back in, you might just want to make a note of Kat's number so that you'll be able to text her directly. And also if you're having any challenges in the Zoom, you can just private message her through the Zoom chat as well. We're not anticipating any technical challenges, but as I'm sure everyone is very familiar with by this point, things happen that we don't expect. So unless I have forgotten anything, I'm going to move into our first speaker. All right, looks like no one's giving me red flags or signs that I've forgotten anything. So we're going to move ahead. And I'm really happy to be introducing Ian Cromwell as our first speaker. Ian is a manager of health economics within the Evidence Standards Directorate at CADTH, which probably has some way to pronounce that acronym that I don't know, Canada's Health Technology Assessment Agency. In this role, Ian leads teams of health economics staff through economic evidence reviews of new drugs to help provincial drug plans make reimbursement decisions. Ian also leads CADTH's working group in R, where he trains staff and builds CADTH's capacity for developing open source tools and models. Ian holds a Bachelor of Science honors in Health Studies and Gerontology from the University of Waterloo, a Master's in Science in Epidemiology and Biostatistics from Queen's University, and completed his PhD at the School of Population and Public Health at UBC in 2019. So welcome, Ian, and I'm going to turn it over to you.
Thanks very much, Shelby. Hi, everyone. Thank you so much for being here with us today. This work, at least my involvement in this work, comes through a series of conversations that have been ongoing within the group of modelers here in Vancouver for a number of years, led largely by my colleague, Dr. Stephanie Harvard, looking at how we use models and when we build models, what are the values and the sort of sets of premises that we consciously or unconsciously bring into the work that we do. And the relevance of those kinds of questions has really become much more apparent over the past couple of years, partially because of the impact that modeling has had when we talk about pandemic planning and the sort of implications of making decisions that are informed by models and making sure that those models are asking the right questions. The other reason why it's become so much more resonant for me is because I have actually shifted into this new role at CADITH, where my job at CADITH is basically to check Big Pharma's homework. They want provincial drug plans to adopt new drugs and fund them through public insurance. And so the question becomes, are we getting good value for what we're being asked to spend? Does the evidence actually support this decision? And so much of the work that we do at CADITH revolves around the use of economic models and understanding what is in those models, not only from the numbers kind of sense of it, but also what are the values that are reflected in those models, and what kind of decisions are we making, and what kind of decisions are we not making as a result of assumptions that are sort of baked into a mathematical analysis. And so today, what I'm going to do is walk you through, just to give you a bit of a grounding in what economic models are, what they're for, and how we use them. Before we get started, I just want to make it clear that the information that I'm presenting here is not necessarily CADITH policies or positions or opinions. These are my own reflections as a health economist, and they aren't necessarily reflective of my employer. I also have no relevant conflicts of interest to disclose. I don't take funding from any group other than my employer. So yeah. So we are trying, with health economics, we are trying to solve a basic problem, which is that there are limited resources available in the healthcare system. And there's new stuff coming onto the market all the time. Drug companies are making new things, device makers are making new things, there are new procedures, new programs, all kinds of new things that are coming on the market to solve healthcare problems. And we can't necessarily, we have a finite budget. And this is the issue that we have to confront. We have high levels of need and new things come in the market all the time, but a limited ability to satisfy that need. And so we have three possible responses to this conundrum. One is that we can just pay for everything. We can just say, anytime someone comes up with a new thing, we're going to pay for it because we want to have the best most cutting edge, highest tech healthcare system possible. The problem that we run into there is, where does that money come from? How could we possibly pay for everything under the sun? The other related question is, some of the stuff that just because it's new doesn't necessarily mean that it's better. It just means that it's new. And we know, not to disparage my colleagues in industry, but just to recognize that there are lots of different ways to make an argument for something being better than standard of practice. And it's not always the case that it is better. Sometimes it's just newer. The other option is to say, or another option is to say, no, we have a good enough healthcare system as it is. We don't need any of this newfangled business. We'll just stick with what's currently working, and all of this new stuff can, someone else could buy it. That we are going to miss out on a lot of potential opportunity, because there is a lot of new and interesting and valuable innovation, and the industry is really trying to take into account the needs of patients, the needs of families, the needs of public health. And if we just say no to everything, we miss out on any potential opportunities for benefit that may result. And so the third option is, okay, we're going to say yes to some of the things so that we can get these benefits. And we're going to say no to some of these things so that we're not spending a lot of money on stuff that doesn't work very well. So then the question becomes, okay, but what are the things? How do we decide what we say yes to and what we say no to? We can't, there's no obvious solution to just, well, we'll just pay for the good stuff. Okay, but how do we define that? And so health economic evaluation proposes a set of rules for how to make these decisions that are guided by generally speaking, three questions. First, how much better is this new thing that we're considering funding? How much better is it than what we're currently doing? We have a treatment for headache. How much better is that than what we currently have to help manage headache? The second question, of course, is how much more does it cost? How much more are we being asked to spend above what we currently, what our current budget is? And then the third question is, is it worth it? Are we getting good value for that additional money, good additional benefit for the additional cost? And by making decisions in this way, health economists argue that we are helping the healthcare system to buy, and I'm being very loose in that sense because it's not quite the same as a market good, but to help the healthcare system buy the most health for the population, so that we are making sure that for each additional dollar that is going into the healthcare system, we're getting the most out of that dollar, the most bang for the buck, so to speak. So I'll give a very facetious example outside of healthcare here. Let's say that you're thinking of upgrading your phone, and there's a new phone, the iPhone 15 or whatever number we're at now, coming onto the market, and you're thinking about, oh, maybe I'll get the upgrade. So you might ask yourself, what am I getting? What exactly is the value of getting the new thing? There might be a lot of new, really cool features. Like when I last upgraded my phone, it has this really good nighttime camera, and I go to a lot of live shows in concert venues that are pretty dark. So having a camera that has a really good light sensor is actually a really big value for me. But also, maybe your current phone, maybe you're still using a Nokia flip phone, and it's just not smart enough. It doesn't have enough capacity. And so if you've got a lot of new stuff that's really good, and the current thing that you're using is not that great, there's a very high incremental benefit. There's a big value that you can get for making that upgrade. And then the question becomes, how much more are you being asked to spend? Maybe you're on a plan, maybe you're with a provider that offers you a heavy discount on the phone, or maybe someone's giving it away for free, or whatever it is. You may see this as having a low incremental cost or a high incremental cost. It might be an extra $1,500 that you're being asked to spend if you're buying a brand new phone outright. And so each one of you has a specific, theoretically, an amount of money that you personally are willing to pay so that you could have this new phone. And the question that you need to ask yourself is, what else could you spend that money on? Should you spend your rent money on a new phone? Probably not. And if all you have in your wallet is rent money, then your willingness to pay is going to be quite low. Whereas if the marginal benefit is very, very small, maybe that cost is not worth it to get the new phone. So these are all fairly intuitive, and I don't think I need to go into a ton more explanation. But these are the kinds of questions that we ask. We just do this in the healthcare setting. And so there's a very important question to ask, which is, how do we measure better? How do we define when we say that this new healthcare thing is better than the current standard of practice? What does that mean, better? And so we tend to look for data within clinical studies, like randomized controlled trials principally, but other places as well. Observational data from like studies that are conducted in the real world. We might look at electronic medical databases, the sort of list of automatically collected features that are stored in the healthcare system. Other places where we might get data about whether patients are living longer, if we're talking about life-saving or potentially life-saving or life-extending treatments. We would try to find information about whether or not it improves the quality of your life, not only the length of your life, but are you living better? Or in a case where we're talking about something where it doesn't have a survival difference, like the headache example that I used before, but you're not going to live any longer, but you're no longer in pain. Your pain has gone down, and so your quality of life is better. Other things, reductions in any other unwanted outcomes. So that could be, adverse events from treatment, side effects of different drugs. That could be falls in some cases, or just any health outcome that we want to see less of. And so we look for how much does what's the evidence that this new thing actually improves those outcomes that we're looking at. And then we have a similar question for how do we measure what something costs? And that one seems like it would be a little bit more obvious, but there's still quite a bit of nuance to it. We'll sort of look at what are the healthcare resources that end up getting used when we switch from one thing to another thing, and that includes the cost of the new thing itself. We've got, we can use the provincial insurance formulary to sort of figure out, how much does an appointment with this specialist cost or this surgical procedure cost? And then, of course, people do trial studies on how much things cost. And so sometimes we go to those sources as well. And then we can include different kinds of costs when we consider the cost of a policy change. So we can look at the simple, straightforward healthcare system costs. So that's the cost of medicines. That's the cost of the new new approach itself. We're talking about staffing time, labor, doctors, nurses, orderlies, et cetera, facilities costs. So if there's new machines that need to be purchased or whatever, we can sort of factor that into the healthcare cost. We also might consider, a classic example is someone getting a drug as an IV versus someone getting a drug as a bottle of pills that they get to take home. That actually also represents a change in cost. That the costs are not borne by the healthcare system; they're borne by the patient. Patients will have to change the way and how much they have to travel. They may have to factor in childcare or elder care, depending on the structure of their family. If they have to take time away from work, if they're working, that has implications. So there are other costs that we may consider. And then there are societal costs. These are very, very much more complicated and much harder to pin down. But sick people are not good for society. And that's sort of why we have a public healthcare system. It's not good when people are sick at an individual level, but it's also not good at the collective level when people can't function the way that they want to. And so we may consider things like changes in their productivity if they are at work, if they have to go down to reduce capacity, or they have to change the nature of their job. If jobs are lost overall, that people, firms close and things because things shut down. But as you can imagine, it gets very, very complicated once we start thinking about health as an input into the overall societal economy. And then there's this last question of how do we define whether or not something is worth it? And This one is really, really hard to pin down. There is some interesting empirical work trying to figure out how much we are willing to pay for certain benefits that we might get. But it's certainly not straightforward, and it's quite contentious. But I guess the question, just to sort of illustrate the point, like, how much would you personally be willing to spend to save the life of someone who you've never met and never will? Take that same person, and we're not talking about saving their life. We're talking about just making it 3 months longer. And that's actually a pretty typical window, especially in the space of like terminal disease. We are extending life by a short period of time, but we're not curing people. What about if they live the exact same amount of time, but they're in less pain, they're in less discomfort? Like that question is implied whenever we do this kind of work, is we are asking the public to make a decision about paying for someone else. And the public is made up of a wide variety of people with a wide variety of interests and motivations and abilities to pay. And so we have to think about, when we say worth it, that's not a straightforward question. So why do we use models for this? A lot of the time, because there's so many things to measure, it's really difficult to actually do randomized controlled trials or even like observational studies that would take all of this information into account. It's incredibly costly to do that kind of research. Like, RCTs are not cheap. You have to recruit a lot of people, and for like rare conditions that affect 1 in 100,000 people, even just the recruitment phase could take forever. And then we have to have sufficient time to follow and observe all of the outcomes to make sure that we have a robust estimate of better and costlier. The healthcare system is not well set up to give us itemized costing information. So that's also an additional piece that we just may not know how much a lot of things cost. That was one of the big surprises when I started this field. I just assumed that there was an itemized list of things somewhere. There isn't. And then we have ethical considerations. Is it ethical to wait for many years to get better data while people are suffering from conditions now, and there's a treatment that's available today? Sometimes it's not ethical to randomize people to receive something new versus receive something old. Like, sometimes there are real other ethical considerations that we have to think of, where it's not conducting a full trial is not the best option. And so we use models as a pragmatic approach to solving these issues. What we do is we'll take the known relationships between events, between outcomes, between a patient's trajectory through the healthcare system, and we will recreate that using software. The idea is that we can try to simulate how people move through the healthcare system, what events they occur to them, what costs they incur during that process, and then any other information that we might find relevant to include. And then we'll as we sort of map out the structure of that, the way that people move will be governed through estimates and sometimes a lot of assumptions about the costs and the percentage of people who experience a certain outcome and the likelihood of certain things occurring. And we'll use that to measure the total impact in terms of costs, in terms of outcomes, for a hypothetical cohort of people. And so what we are able to do by making adjustments to the parameters that inform the model, those estimates and those assumptions, we can simulate the total costs and the total outcomes of life, a parallel universe where we have the new thing, and a hypothetical universe where we're doing standard of care. And then we can compare those, and we can get our incremental cost, our change in cost, and our change in benefit. And so this is where models really show up, is that we can get some useful information. It's not nearly as precise as a clinical trial would be, but it does give us useful information about what is the likeliest impact of this policy, and how certain are we that this is going to be the outcome. Is it a coin flip that this thing is better, or do we have really, really robust evidence that suggests we're going to get more health and we're going to get it at a cost that we can predict and understand? So I've just as a quick example, I wanted to show you a model that I built with colleagues at BC Cancer a number of years ago. And this was about using a molecular assay, so a genetic test, basically, the way that oral cancer works is you'll get small growths inside of your mouth, and most of the time, those growths are completely benign. They will not turn into cancer. They're just unusual, what are called leukoplakias. But some of them will turn into cancer. And the idea is to use a genetic feature in these cancers, or these potentially precancers, to predict which ones are likely to transform and which ones are going to stay the same. So the current standard of practice is we just don't know. We literally have no idea what's going on inside your mouth. You're going to keep coming back to clinic every 6 months, and we're going to see, has it grown? Has it changed in shape? Has it changed in size? Has it changed in color? And periodically we'll do biopsies and we'll check. And then when we see evidence that it's progressing, then people they'll get surgery, and that will, most of those will be locally controlled oral cancers, but some of them will progress and become more serious disease. And so we have this model that sort of simulates patients going to the clinic again and again and again, and then a handful of them entering into this cancer process. So this is the current standard of practice, or it was at the time. And oh my gosh, I have made a horrible mistake, and I have took the new thing is the same as the old thing. But basically, the idea here is that we would apply the molecular assay, and then we would be able to know people who are low risk, they can come in less often. So instead of coming in every 6 months, they're going to come in every 5 years, because the evidence is really strong that people with low risk disease are not going to develop cancer, and we don't need to observe them as often. People with intermediate risk, where it could go either way, we see them every couple of years, but because we know things about the disease itself, we don't have to see them quite as often. And then people who are high risk get surgery immediately. And so what we'll see is there's fewer people coming into they're coming into fewer appointments, and fewer people are actually developing cancer long term. That's the hypothesis. And so we built this model that sort of simulates these two different realities. And then we populated that model with a whole bunch of data. I'm not going to walk you through this. Nobody has time for that. It's in the literature. If you're really, really curious, you can check it out. But you can see that there's quite a bit. There's a lot of data. It's a data-heavy process, and we have a lot of information that we sort of incorporate. And it comes from a lot of different sources. And then what we found here is that, as we predicted, we saw a reduction in the number, a change in the pattern of resource utilization in the healthcare system, and that overall we saw a reduction in cost, and actually an improvement in life, in both overall survival and quality adjusted survival, because fewer people were getting sick. So in this case, the decision is real clear. We're reducing costs of the healthcare system, and we're getting more benefits. So not only do we like the new thing because it works better, but it's actually cheaper for the healthcare system overall. That's pretty abnormal. Usually what we see is there's an increase in costs, that we know that it's going to increase the healthcare system costs, and maybe there's going to be an increase in quality adjusted survival. And that makes it very, very difficult to sort of make an easy policy decision. So at CADIF, we get models like this, and they are submitted to us by the drug companies. And they'll submit a whole bunch of trial evidence and other information, and an economic model. And then my team at CADIF takes those economic models and we poke at them, and we prod, and we ask really critical questions to try to get at what assumptions are most influential, what parameter changes are reasonable, are they overestimating the benefit, are they underestimating the costs, so that we can estimate the likely impact if the drug programs across the country did actually fund this new drug. And then we take these evidence, we sort of write this all up into a report, and we take it to an executive committee. And the executive committee, which is made up of scientists and medical doctors, will make recommendations based on the evidence. And so we're talking about millions and millions of dollars of public healthcare funding that gets directly influenced by the work that we do with these models. And it allows us to say yes to some things, and it allows us to say no to some things. But despite the fact that we're doing all of this poking and prodding and sort of deep investigation, we still see an increase in drug costs. Canada is an outlier among OECD peer countries. So do we just keep growing the budget forever? Like, do we just keep increasing and paying more and more and more? Where does that money come from? Another aspect here is that the reports are public, but the decisions often get made before the public actually sees the report. And so just to sort of hammer this home, decisions are being made using models that affect the public. Our money, our health is being influenced by these models and the appraisal thereof. And it's an important question to ask. If the public is being affected by these decisions, what role do they have in deciding how the models get made? What role should they have? How much input should we have when we talk about these things, given that these decisions affect us? And then how do we make this information accessible? How do we actually make it so that people can make an informed input to this? And so we brought this question last month to a group of model builders, some of whom are in the room today. Hello, folks. And we just asked these three basic questions. What are the current processes that we use in our work to involve stakeholders? So that's patients, that's the public, that's other groups. Second, how do you feel about that? Like, what is the perspective? How valuable, how useful is that public engagement process? Where are members of the public, where are the stakeholders able to provide valuable input that helps change and inform your work so that it's better and more reflective of the decision context that we're trying to simulate? And then finally, what we talked about, what are people's perspectives on increasing the transparency of these models themselves, making them accessible to people so that they can really see how the sausage gets made, so to speak. And this includes making these models open access so that you or anyone that you know could log on to a model and see it and play around with it and understand really, like, at a very granular level how well how it performs and what it's predicting and what those predictions mean. And so Sam was with us for that meeting, and I'm hoping to give Sam's hardworking hand a break here, because we've already got a great graphic representation from the last session. And so you can see here, this is the CADF process that I sort of described to you here. And this is not unique to CADF. There are health technology assessment agencies around the world that do this kind of stuff. We take patient input from, we go to patient groups, we go to drug plans, we go to clinicians, and we ask for their input. And when the drug companies submit evidence, the health economists at CADF look through and say, okay, how have these values, how have these preferences been reflected in the structure of the model? We want to see. I think there was a general consensus that we do want these. We do recognize the importance of having stakeholder input, not at one place necessarily, but throughout the process, so that we can make iterative changes as we go along. We also recognize that there's a difference between the perspectives that patients bring to the table from the perspectives that members of the general public who are not patients may bring to the table. They have different sets. In many cases, they overlap, but they have different sets of values and different sets of priorities. And it's important for us to be thinking about, well, what are we going to actually do with this information? Are we just going to take it and say, oh, that's nice? Or are we going to actually have a process to incorporate it? How do we make that valuable? How do we make that resonate so that we're not just asking people for information that we have no ability or interest in actually reflecting in the decision that gets made? And so when we think about increasing the amount of stakeholder involvement in the modeling, that's where things get a little bit more complicated, because we don't have a consistent set of guidelines. It's not something that we have sort of a method for doing. The other thing is that model building is not it's faster than running a randomized control trial, but it's not fast and it's not easy. And we spend a lot of our time just trying to get the thing to work in the first place. And you know, sometimes we have teams of scientists who are working on this stuff for months to get it to work. How do we get patients? What is the reason why a member of the public or a patient or both would bother to participate in the first place? How do we get them to actually come forward and engage with us? And how do we recognize the time and expertise that they're offering us? That's also an issue that we discussed. And then finally, on this transparency piece, I mean, there's a lot of different definitions of the concept of transparency. But you know, as I speak to you today, I'm trying to avoid lapsing into sort of health economic jargon and speaking the way that I would speak to one of my colleagues in terms of, you know, oh, let's conceptualize parameter uncertainty and make sure that we're constructing an appropriate cost effectiveness acceptability curve. And all of that is just nonsense if you haven't spent a lot of time in this space. And so when we talk about transparency, it has to be fully transparent, not only in just putting the information out there, but it has to actually be accessible. And then there are some basic, straightforward logistical questions. Who's going to pay for us to make this stuff transparent? What happens if someone takes work that we do and they use it for a different purpose? Who owns that information? And what are the downsides of making these things fully transparent? Are we sharing code? Are we documenting? Are we writing up? It is in a complex space that we're trying to move into. And that's why I'm so excited about the work that we're doing today, because this sort of points us towards how we can all get the most value out of working together in this way. So really quickly, and I know I'm over time, and I apologize to my colleagues for going a bit over time, but I did want to summarize what we did in the last session. Just to wrap up, the high points here. We use models. Models are the genie's out of the bottle. We are making healthcare decisions based on the results of these economic models, because we are trying to help the healthcare system get the most health for each dollar that we invest in it. It's everyone's healthcare system. It's everyone's healthcare dollars. And so we want to make sure that everyone is benefiting to the highest extent possible. Models themselves are based on assumptions. They're based on estimations. They are themselves a simplification of reality. And as a consequence of that, there's going to be a lot of uncertainty, a lot of subjectivity, and making a lot of judgment calls when, you know, a drug company says that the cost effectiveness is X and CADIS says that the cost effectiveness is Y. Neither of us is correct. We're just using a different set of values. And I mean, pumping my tires just a little bit, I mean, it's closer to Y than it is to X in almost all cases. So, you know, we are trying to achieve this sort of maximizing population health. And then from modelers, whatever sector they work in, I think there's a clear interest in having patients and the public provide us with input and to have your values and your priorities reflected, but there's no clear consensus on how that happens, where that happens, when that happens, and how we make it so that there is actual additional value to the public when we ask them to participate in this process. And with that, I'm going to wrap up. Thanks so much for your attention. This is a topic that I feel really strongly about. I hope I've been able to sort of give you a bit of a background as we start to have this discussion about why this work is important and some of the questions that we're going to try to address together over the next, cumulatively 3 hours-ish. Thanks so much.
Thank you so much, Ian. That was great. We do have time for just a couple of questions. If there's anyone who's looking for clarity or a little bit more information on anything that Ian spoke about, you can feel free to either pop those questions into the chat or use the little icon to raise your hand. Yes, I see Shazad and then Anya.
Hi, Ian. Thank you so much for the great presentation. I have a question. When you are working with pharmaceutical companies, would you receive their models to test whether the results are, oh, so you actually have the model and you play with the model, tweak the numbers? Okay, and are they coming in different programming languages?
We require them to be submitted in Excel unless there is a really strong justification. Otherwise, there are some historical reasons for that I won't get into because they're not all that interesting. But part of the work that I'm doing at CADIV is to push us into accepting and building models in R. R lends itself much more easily to collaborative programming and sharing, and so that's some of the work that I'm doing there.
Sorry, just a follow-up question. So would you like communicate with the modeler to be able to understand their model? Like, how is the process?
They had to submit like a pretty comprehensive technical document. We try not to have too much back and forth. That just it ends up eating up a lot of time. It is the responsibility of the industry to make sure that we can understand what they did. And if we can't understand what they did, then either we try to figure it out, or we ask them, or we just say, we couldn't figure out what they did, get a bigger price discount.
Okay, thank you.
Go ahead, Anya.
Yes, thank you, Ian, for a great presentation. I really enjoyed that. I have a question because I'm participating in this as a patient partner, and my interest is, how do you choose though? Because you were saying about you have several, some of them are patients like that you're consulting, or somebody else, or whatever, however you get the data. Some of them are patients, some of them are not patients. Like, I'm just interested, how do you make sure you have a good sample representation of different factors? You said also you have general public people that are not affected by any of the decisions that need to be made. Let's say somebody that doesn't have cancer makes, gives input on a cancer drug or something. I'm just saying, how do you make sure you have a good representation? Because I sometimes feel the way people are chosen is not really fair and democratic.
So this is a really excellent question, and thank you, Anya, for raising it. And I hope that my colleague Sarah Burglas, who is here, who is the head of our stakeholder engagement team at CADIV, I'm sure that she's riveted by this question too, because this is something that we actually really struggle with. We just to be clear, the CADIV process does not include members of the general public. We don't consult non-patients for this. We get information from patient groups. Now, arguably, they are not necessarily representative. And I think we struggle with how do we actually make sure that we are balancing different considerations, especially when we talk about, equity-seeking groups, people who have been denied access to healthcare, people who have been denied access to equity for various structural reasons. If we don't hear from them, does that mean that their input is not valid, that it's properly represented by our current processes? And so this is an ongoing challenge, and it requires an ongoing process of renewal. And so that's why Sarah's here. That's why some other folks from CADIV are here, because this is a question that we are actively asking ourselves: is how can we achieve that balance that you're talking about? Because there is, as you've identified, a real challenge and a real potential shortcoming in whose opinions we reflect in the way that we do. So I unfortunately don't have a satisfying answer for you to this question, except to say I share your concern, and this is something that we are aware of and that we are working on, and that this work that we're doing today is designed to try to address.
And I think also, Anya, that's exactly the kind of conversation that we are hoping to have a little bit more of tomorrow. So yeah, like Ian said, great question. And there'll be a lot more time to expand upon those questions and that kind of thinking tomorrow. So thank you for that. I do want to move on. I see your question, Jamal, and we need to move on so that we ensure that we have time for all of our speakers. But Jamal, if you want to put your question into the chat, We'll see if we have time at the end to circle back. So thank you. And I'm glad that that we're sort of already getting people thinking about questions and things that they want to talk about. That's awesome. So thank you. So we're going to move on to our next speaker. And our next speaker is Stephanie Harvard. And Stephanie is a Michael Smith Health Research BC postdoctoral research fellow at the UBC Faculty of Pharmaceutical Sciences. Excuse me. Her work focuses on understanding and communicating the role of social and ethical values in computer modeling and exploring new ways of informing health-oriented models with patient and public values. She's the co-developer of the Pure Models Network, an online initiative which focuses on optimizing patient and public involvement and transparency in modeling, including through educational videos and open access models. She's also the co-director and producer of the short film Moral Models: Crucial Decisions in the Age of Computer Simulation, featuring philosopher Eric Winsberg. So Stephanie, I'm going to turn it over to you.
Okay, thank you so much, Trilby, and thank you everyone for being here today. I'm going to just share my screen here. Okay, that's the end of my presentation, so let me go to the start. Okay, so the focus of my presentation today is actually the same as the title of this event. So, how can health economic models best reflect patient and public values? So I'm going to start off today by just defining what I mean by the term value judgments and explaining in what sense I think that health economic models are value laden. So once we're in this context, it's really natural to ask if we're doing the best job we can do of managing these value judgments. In the second part of the presentation, I'll just move on to some of the things that we might consider doing to help us. So one thing is involving patients and the public directly in modeling. And the second is in some way enhancing or changing our practices around transparency in modeling. So first off, what do I mean by the term values? People define this term in a lot of different ways. But for my purposes, I actually use a definition that our co-speaker today, Kevin, gives in his book. And he writes that, broadly speaking, a value is something desirable or worthy of pursuit. So basically, when I speak of my values, I'm speaking of things that I think are good. And further to that, I'm speaking of criteria that I can use in my life to try to help me choose between different possible courses of action. Now, we can break down different types of values in a lot of different ways, but one really basic distinction that we can make is between values that sort of seem more scientific in nature versus values that seem to be more social and ethical, including political. Sometimes the scientific type of values are called epistemic values, which means that they relate to knowledge. And the more social or ethical type are called non-epistemic values because they relate to things other than knowledge. Oh, I'm going to run into my advancing the screen problem, Trilby. Hang on, folks. This is what I always experience in giving a presentation. Hang on. Oh, there we go. Okay, so these quotes here are examples of how these terms are used by philosophers of science. So, for example, Daniel Steele talks about epistemic values as values that promote the attainment of truth. And Eric Winsberg talks about social values as our estimations of what's important and valuable in the typically social and ethical senses. So if we think about, here we go. If we think about our social and ethical values, we might come up with examples like I've done here on the right. So things like justice and health, choice, affordability, dignity, and things like this. And if we think about our scientific values, we might come up with examples more like internal consistency and predictive power, accuracy, unbiasedness, and things like this. And we might even think of some values like simplicity that sort of seem to be on the border of our two categories. And what this tells us is that the categories are not really set in stone. So why is it worth thinking about values? And why is it worth thinking about these types of distinctions? Well, one reason has to do with something called the value-free ideal for science. And if any of us have heard ideas like, scientists should be neutral, they should be impartial, they should be objective, then we've all been exposed to this ideal. And what the ideal suggests is that when we're doing the practice of science, we should be really careful about the influence of our social and ethical and political type values. And more specifically, we should limit the influence of these values to sort of what we see as external parts of the scientific process. So let me say a bit more about this. So, science involves a lot of different types of activities, and there seem to be three that are definitely acceptable to influence with our social values. So, for example, when we're picking the topic to study with scientific research, we seem to be drawing on our social and ethical values in actually sort of a good way. So, for example, if I study arthritis treatment, like I did in school, it's because I think it's good to know more about the costs of arthritis, how to improve care for people with arthritis, and things like this. It's not necessary for me to be neutral about that. Furthermore, when our research ethics board says that we should have informed consent from research participants, it's because they have good ethical arguments for that. Finally, when scientists report their study results and policymakers listen to them and they decide how to act on them, that obviously involves deciding what is good to do, what's the best possible course of action in a really social kind of way. So most people will agree that our social values legitimately influence these decisions. And many will say that in some sense, they seem like external parts of science. But at the same time, there are other scientific decisions that seem to be just not acceptable to influence with our social ethical type values. So some of the examples are things like choosing what evidence we want to collect, deciding how to test a hypothesis, and definitely justifying the claims that we're going to make in scientific papers. These are decisions that we have a strong sense that we don't want social, ethical, political values to influence. And in some sense, people feel like these are internal types of decisions, like they're decisions that make up the very heart of scientific reasoning. So the value-free ideal for science basically says, let's just be using our scientific values when we're doing this core type of reasoning. And there do seem to be really good reasons for us to adhere to the value-free ideal. So for example, we don't want to fall into what philosophers call wishful thinking. We don't want to fall into saying that something is true just because we want it to be true. And furthermore, we really don't want to give an undue amount of power to scientists in a way that would be undemocratic. So these are reasons and motivations for having the value-free ideal. But we run into a problem because as much as it seems like an important ideal, the more we scrutinize it, the more we find ways to poke holes in it. And the more we think, it looks like there are social and ethical value judgments that just are unavoidable in science. So the way that I think about these value judgments is they're decisions that basically have both flexibility and social impact. So to quote a paper, scientists agree there's more than one legitimate way of doing things, and there could be social or ethical consequences following the decision, whether that's immediate or down the line. So given that this is the reality, arguably our focus should not be on trying to prevent value judgments. Rather, it should be on how can we manage them? How can we manage them appropriately so we are preventing wishful thinking and we are protecting democracy? And I think to do this really well, we need to be mindful of how value judgments look in these really diverse corners of science. And this includes computer modeling. And it definitely includes computer modeling in health economics. And like Shelby said, health economics models, they're the ones that we use to estimate the costs and benefits of different health treatments. So when we're thinking about value judgments in computer modeling, I think it can be helpful to think about the nature of computer models. So, in a nutshell, computer models are representations of things, and we use them as tools. So, in other words, like Ian was describing, we build this model, and it actually stands in for this really complex system that we want to study. That's what we mean when we say it's a representation. It stands in for something else that's more complex. And these representational tools can help us think through problems, the very type of problems that Ian described. So how much better is a new treatment than an existing treatment? And how much is it going to cost? Is it going to be worth it to us? And so on. But something to keep in mind about models as representational tools is that they seldom include everything. They are tools that are meant to be adequate for our purposes. They are not true in a sense. They are not perfectly accurate, complete depictions of things. So we can always have this legitimate worry that models will exclude relevant information and they'll become tools that are not adequate for our purposes. So I tend to think about value judgments in modeling in three different parts. So first, I think there's value judgments when we're deciding what to represent in this model. So in other words, decisions about what to include and exclude from the model. So the decisions in health economics about what to include in models are all the major things that Ian described. So for example, let's talk about picking the new treatments. We might very well have a concern that we don't have all of the possible treatments on our radar. We might be concerned that maybe there are prevention programs, for example, that are not getting the attention that they deserve. But even if we, drill down, we choose the treatment that we want to look at, we then have to choose what we're going to compare it to. And we might worry that by choosing a thing to compare it to, we're choosing something that's actually going to be misleading. Maybe we're misrepresenting the range of our current options. Maybe there's an option out there that we're not thinking about, and we should be comparing it to that. There's also the choice of what health outcomes we want to look at in terms of deciding, is this a good effect, right? So, perhaps I think that the health outcomes that matter to me include things like stress and anxiety around my condition. But even if I think that, I might have a colleague that says, it's not really appropriate to include that, it's just not a priority. We also have to worry about what specific healthcare costs we're including in the model. So for example, as a patient, I might very reasonably want my out-of-pocket costs to be considered. But again, I might have a colleague that says, that's not the priority, or maybe it's just too hard to measure. Finally, there are a lot of factors that we can think of that might influence the costs and benefits of different treatments once they're out there in practice. So for example, this might include different patient characteristics. So we might want to ask ourselves, well, which of these characteristics are we going to consider and include in the model? Keeping in mind that people have a lot of characteristics, and it's unlikely that we're going to be able to consider every last one. So how do we decide what makes it into the model and what doesn't? So I think it's possible to recognize in what sense these are value-laden decisions. And the way that I think about it is effectively our answers to these questions are our social and ethical judgments about what is and is not part of our research question. Okay, so the next kind of category that I think about is these value judgments about how we're going to represent the things that we've already decided have to make it in. Now, these are decisions that concern some of the more technical things that Ian touched on. So for example, what data sources are appropriate for us to use? We know we need model inputs. Where are we going to get those from? Further to that, how accurate do these inputs need to be? And in particular, to what extent do we need to explore the potential effect of getting some of those inputs wrong, given that we know we have a lot of uncertainty around these things typically. In one sense, I think these decisions can be understood as also reflecting our research question, because our curiosity about the effect of uncertainty is actually part of the research question. But the question is, how much of that uncertainty exploring are we going to do? And then there's also kind of a second sense in which these decisions are value-laden, which is they seem to kind of reflect our risk preferences. They reflect my preferences around, well, how accurate do I have to be around these inputs? And it's very widely appreciated that how we respond to risk reflects our ethical values. So finally, we have to make value judgments at the stage of model interpretation. So when we're deciding what are we going to conclude here on the basis of this model? And more specifically, what are the facts? What are the facts that we're going to provide to policymakers? Do we know enough to make recommendations to policymakers? Should we maybe collect more data or tweak our model in some respect before we say anything? These are all questions that pertain to how certain we think we need to be before we say something is true. In certain situations, we might demand a very high standard of evidence before we report facts to policymakers. And in others, we might say, well, we don't have too much evidence. We're not too sure, but we're still prepared to tell you what we think is the fact of the matter. So ultimately, both developing health economic models and interpreting them requires that we make value judgments. So it brings us to our question: how should we manage these, and how can we be sure that they reflect patient and public values? And I think at least two different initiatives might be beneficial in this context. The first is the idea that we involve patients and the public directly in the modeling process. The second is the idea that we enhance some other forms of transparency. So to start off with patient and public involvement in modeling, this is an initiative that is actually already well underway, including in BC here. So we actually have a number of people with us today, modelers and patient partners, that already have experience working together to build these models. But the exactly right process for us to follow is just not totally well established yet. We still have issues that we need to think through. And a lot of these issues were brought up in a qualitative study that we did not long ago, where we asked health economic modelers about the idea of patient involvement specifically. And in this study, the participants talked about potential benefits of involving patients, as well as potential harms. And they also brought up a number of factors, so different variables that they were interested in, things that they thought might affect the overall net benefit of involving patients. So I'm just going to tell you a few of the things that folks were saying. So roughly, participants were talking about three different types of benefits that you might think of. So there were benefits to the model itself, there were benefits to the process, and then there were benefits to modelers themselves as individuals. So for example, some participants said, patient involvement might actually help to ensure that these models are including the right things. They're including just the stuff that's relevant, and also that whatever they do include remains consistent with patients' factual knowledge. Some also said that in some sense, it might make the modeling process more legitimate. So maybe more democratic, maybe more objective, or transparent. They also said because of that, that would make the model building process just more adequate for conceptualizing the model and then ultimately for informing decision making. And people thought, maybe there would be benefits to the modelers as individuals. So for example, maybe having patients involved would give modelers a sense of greater interest in a particular process, make them more passionate about the project. Maybe it would increase their knowledge about the topic, help their communication skills, and ultimately have a beneficial effect on how they make decisions as a modeler. One thing that I thought was interesting was that no one mentioned any direct benefits to the patient. So that's an open question. Now, in terms of harms, some participants were worried that involving patients would have the opposite than intended effect. So they thought, well, maybe this model is going to end up with things that are just not relevant. Or maybe it's going to end up with kind of too much in the model. Maybe it's going to make models overly complex. And maybe that's going to make the results of a model just ultimately too hard to communicate to people. They also talked about the potential risk of slowing down the modeling process, maybe in some way reducing the scientific rigor, or just complicating the project management side of things. Some people also expressed concern that maybe modelers would not be comfortable working with patients. But they also worried about effects on patients themselves. So this included worries that, maybe modelers would involve patients without being able to guarantee that what they would contribute would be meaningful. And to do this would be something akin to tokenism or maybe paternalism. And people also just had a straightforward worry that the process would be a burden to patients and that it would just be unnecessary and maybe that they could become offended in the process. So in terms of all the factors that people wanted to know more about, one of them was the goal. So people wanted to know what exactly was the goal of patient involvement and whose values exactly were supposed to be incorporated into the model. So is a model supposed to represent sort of widely held values? Is it supposed to represent a diversity of values, like competing ways of thinking about things? Or should it just reflect the values of whoever is going to be using the model eventually? They also had a lot of high-level questions about the procedures. So how are we going to recruit patients to be part of this? Are we going to recruit patients to be involved in every single modeling project, or is it just going to be large-scale projects or specific special projects? And exactly how is the engagement going to look? Is this going to be one-on-one all the time? Are we using focus groups? Are we using surveys? And what are the timelines for all of this? So they had a lot of concerns about those different things. And another specific concern was, what is the nature of the patient's role? So for example, what decisions are patients going to be involved in? Is it going to include every technical decision about modeling? And also, how much influence over decisions are patients going to have? Are they going to have the final say, or how is that going to look? They also really wondered, if we're inviting patients to be part, are we inviting members of the public to be part? Will there be clinicians? What's the balance of the numbers? Who exactly are folks going to be? And also, how are the power dynamics going to work between all of these participants? And then there was another note about, people have different personal characteristics. So for example, folks wondered on the patient side, what sort of capabilities would patients have? What type of training and background would they have? And what would their different perspectives be? And then with respect to modelers, people questioned, what will their level of sort of belief in patient involvement be? What will their experience be, having worked with patients in the past? Will they be open to change? What kind of assumptions are they making? Do they have good communication strategies? So there was a whole spectrum of concerns about, how people are as individuals and whether it would work in the process. So I think when we're thinking about patient and public involvement in modeling, we should think about all those factors that people mentioned. But there are other considerations too. And, here are just a few that come to my mind. So first, like I think Ian was sort of referring to, sometimes it seems like health economic models are only relevant to specific patient groups, specific patients that are maybe advocating for a specific drug. But ultimately, these are models that affect everybody because they really influence health resource allocation decisions. So we want to think about involving the public as tax-paying citizens, but at the same time, is there an interest? And how to do that, how to inspire interest among members of the public to be part of this complex modeling process that might be on a condition that you don't have. The other thing that I think we should remember is that there are published guidelines about how to do health economic modeling. And these refer to not every single modeling decision, but some of the decisions at a certain level. And so we might want to ask, okay, well, in what sense are we going to involve patients in the public in developing guidelines? And would this be a substitute for direct involvement, or would this be complementary? Finally, I think it's just good to know that there are increasingly complex data being used to inform models. And there's a huge range of model types that are being developed, which not even every expert is familiar with. So this complexity might complicate things. And arguably, there's always going to be technical aspects of modeling that really only experts can evaluate. But at the same time, I think all of us might want to increase this sort of technical evaluation, and we might want to know the results of it in language that we can understand. So moving on to transparency in modeling, I'm going to draw here on some work that our colleagues did, led by Chris Sampson. So these folks were talking about the idea of increasing transparency, both in terms of increasing the completeness of information and also the accessibility of information about health economic models. And they review a number of different ways that we might do this. So for one, we might strengthen reporting standards. So, we're asking for more information to be, openly communicated about models. We might also produce more of what they call reference models. So basically, standard models that researchers would be encouraged to sort of follow and adapt for different settings. There's the idea as well of just increasing the amount of direct collaboration between modeling teams so that there's this process of transparency between experts. So there's just more eyes on what different teams are doing. We might also consider enhancing the peer review process. So the point at which people are publishing scientific manuscripts and other scientists review the work. In some ways, we might consider changing or making that even more rigorous, or just done in a different way. And finally, they talked about this option of building open source models. And that's the option that I'm going to focus more on today, because it's relevant to a lot of work that we're doing with Peer Models Network. So open source models are basically models that they're fully disclosed, and there's unrestricted access to what they call the model source code. So I think most of us have ideas now about what model code kind of looks like. Coding is a phenomenon that we hear more and more about. So making this type of code openly available might have the effect of encouraging more modelers to be involved in evaluating and maybe also replicating each other's work. And this might be helpful, both in terms of increasing attention to different value judgments that different groups are making in the modeling process, and maybe also just detecting errors that might pop up. It might also encourage modelers to reuse models, to adapt them for different settings, and try to improve them over time. So potentially open source models could just make things more efficient and over time improve model quality. But at the same time, there's a concern that just sharing model code might actually just not be enough. So one reason for this is modelers often tell us, model code can be kind of messy. It's a bit personal. And using someone else's modeling code is maybe trying to decipher someone else's grocery list. It's not necessarily always clear, right? Furthermore, the code alone is not necessarily enough to actually run a model. You might need additional data, you might need different software, you might need better hardware and things like that. So to go one step further, we might invest in producing what we can call open access models. So these are models that users can run directly without using model code, and also without additional software or hardware requirements, and actually without too much technical knowledge. So we have an ongoing project at UBC, which is called the PRISM project. And my colleagues Mohsen and Amin have developed this, and it aims for this goal. So basically, PRISM is an online infrastructure that allows for users with reasonably limited technical ability to interact with models that are hosted on a cloud type platform. And to do this, people have to learn a standard language, but it's vastly less complex than model code. And further to that, they can run these models on their computers at home without any additional software or hardware and so on. So this is a screenshot from a tutorial video that we made about how to access models in Excel using the PRISM platform. So just the one thing I want you to notice here is that it provides a way to change model inputs directly. So you don't need to use model code. And then the next thing to notice is that the model results get presented in a way that's relatively simple, and it makes it pretty easy to see the effects of making a change to a model input. So in principle, increasing the number of open access models could encourage more experts to be involved, in evaluating models and replicating models. And this could increase the efficiency of the process. But, moreover, in principle, because it takes away some technical requirements, it could allow for more members of the public to participate in reviewing models. And this might be something that we would want to consider, particularly in cases where there's a public demand to understand the rationale for certain decisions. So we might think of decisions, for example, not to fund a particular treatment, or maybe to pay a particular high price for a treatment, or to fund specific vaccination programs in specific groups and so on. So decisions that the public often does become interested in. So something to keep in mind is just that, depending on our goals, open models may or may not be enough on their own. There might be another need to sort of consider the documentation that goes along with models. This might include things like descriptions of data, descriptions of the value judgments that go on in the modeling process, maybe the records of validation and things like this. And maybe there's a need to produce this in more plain language that would be more accessible to non-experts. And to go along with that, maybe it's necessary to develop more education and more training for different model users. But at the same time, there may or may not be a demand for this. The other thing to keep in mind is maybe there are reasons to limit open access models. We might have concerns around potential harms that would result from making models too open. So for example, we might decide that just our resources would be better spent elsewhere. But we might also worry about the potential misuse of models. And we might have other concerns that would apply to specific modelers or specific teams in terms of intellectual property or legal concerns or privacy concerns. And then there is the concern about what is this doing to the workload and in what sense is it going to delay the modeling process. So I've covered a lot of open questions here that stem from this topic. And in fact, there's no way that I could cover all of the intersecting issues. There are a lot of people here that have knowledge that I really am excited to have shared tomorrow. I just want to add a couple of questions that come to my mind. So the way that I'm, things that are kind of bumbling around in my head right now is, what's the right way to think about the connection between patient and public involvement and transparency in modeling? In some ways, these seem like complementary strategies, and I wonder if we want to think about how the balance of them works together. But at the same time, it's clear that they do accomplish some distinct goals. So I'm interested to hear Kevin's talk, because he's going to, I think, give us more insight about this type of thing. But really on my mind is, what are the priorities that folks have around these topics? Where should we focus our efforts to ensure that health economic models, reflect patient and public values? Right now, I think, as I mentioned, we have this project, there's the PRISM project and the overarching Peer Models Network project. And we're basically focusing on 3 different things. So first, we're focusing on building the PRISM platform. So developing more open access models and making sure the infrastructure works well. Second, we do some creation of educational videos on models on different topics, different aspects. And then third, we work directly with supporting patient involvement in modeling on specific projects and trying to think about our methods there and how to improve them. So I guess the question that I have is, are we focusing our efforts in the right place, or do we need to think differently? So just to end off, this is a screenshot of our YouTube page, and I gave the link to that to Trilby. If you don't mind adding it to the chat at some point, people might want to check out some of the videos that we have, which includes this documentary that we did not long ago called Moral Models, Crucial Decisions in the Age of Computer Simulation, which brings up a lot of the topics that we talked about today. These are the papers that I mentioned. So if anyone wants details, you're welcome to email me. And yeah, that's it for my half. I'm looking extremely forward to hearing from everybody tomorrow. Thank you. Let me press escape here and stop sharing.
Great. Thank you so much, Stephanie. We do have time for 1 or 2 questions before we move on to our final speaker. So if folks have questions, please, raise your hand or pop those into the chat. And Anya, I see you have a question, so please go ahead.
Yes, Stephanie, what a great presentation. Thank you so much. It got me really engaged and interested. And I'm totally floored that nobody has any comment on the benefits to the patient to be part of that. I made a whole list while I was listening because I bring patient perspective. And for me, what patients would definitely benefit is for some of them, or quite a few of them, it would be a meaningful activity. They contribute their own skills. You mentioned that a little bit in your presentation as well. And just, to be involved as a citizen in decision-making that are socially impacting. I mean, that is a big benefit as well. Anyway, I can go on and on and on, but I just want to say that I'm totally surprised nobody said any benefits for the patient. So anyway, I just want to mention that. Thank you.
Thank you, Anya. Yeah, I wonder in some ways maybe if participants didn't want to speak for patients, but I also have that question on my mind. I would love to hear from patients and also members of the public about what types of benefits they see to themselves potentially of being involved. So thank you for that.
Great. Any other questions for Stephanie before we move on? Okay. Well, we're going to move on then to our third speaker. And our third speaker is Kevin Elliott. And Kevin is a professor of philosophy who specializes in the philosophy of science and practical ethics. His work focuses especially on understanding the influences of ethical and social values on scientific research and managing those influences responsibly. This includes efforts to address financial conflicts of interest and to promote greater demographic and disciplinary diversity on science teams. Much of his current research focuses on efforts to increase transparency in science, enhance the effectiveness of the open science movement, and promote better science communication. He's the author or editor of several books, including Values in Science and A Tapestry of Values, an Introduction to Values in Science. So welcome, Kevin, and I'll turn it over to you.
All right, thank you. So let me share my screen and just let me know if there are any problems with seeing it. So yeah, thank you so much for the invitation. I won't chew up time doing too much of an introduction, but I really appreciate the opportunity to talk with you all and to learn more about the details of transparency in health economics modeling. I'm going to give some sort of broad thoughts about transparency, about values, and then hopefully this can feed into the further discussions tomorrow. So first, I want to just give a little bit of a background on sort of how one might come to transparency and values in science and think about that. Stephanie already did a nice job of this, so I'll try to refer to things that she talked about. And then Stephanie suggested that it would probably be helpful for your purposes for me to kind of lay out this taxonomy of transparency that I talked about in a recent article. I think as you all think about transparency in modeling, it's helpful to think about these different dimensions. So you may want to be thinking, well, what exactly are our purposes? What are the audiences that we're trying to reach? The content that we're trying to communicate, and so on and so forth. So I'll talk about that in the second part of the talk. And then sort of drawing from that, I'll highlight that there are important judgments that go into pursuing transparency itself. So one really needs to think about, well, how exactly do we want to do this? And so some of this involves weighing some of the dangers and benefits that Stephanie was touching on in her talk. And then once you start thinking about this taxonomy, one realizes you have to kind of have to choose what kinds of transparency are actually most important to pursue in particular contexts. And Ian also sort of led into this really nicely, deciding how to frame the information provided. What kind of explanation do you provide so that people can actually make use of this information? So anyway, Ian and Stephanie set things up really nicely for me, and hopefully this will give you some more things to think about for the discussion tomorrow. Okay, so turning to the first part. So what I would note is you might come to this concern about being transparent about values and value judgments in science from kind of two different paths, and we may want to keep that in mind. So one is you might be starting from a desire to promote open science and think that's really valuable, and then realize, well, values and value judgments are one of the things that we should probably be open about. Or you could kind of start with an interest in the ways that values influence science and then realize, openness and transparency is one of the really helpful ways to actually manage values responsibly. And so it's worth just kind of thinking about both of these angles. So just a really quick introduction to the open science movement. This is a document from the National Academies of Sciences in the US, where they defined open science in terms of its goals as making scholarly publications available and usable to people, as well as the data underlying them, and the code or the algorithms like we've been talking about, underlying models and so on. But I really like this figure. I'm sorry it's a little fuzzy, but it's from a funded project in the European Union that just highlights how broad the open science movement can actually be. You've got that green hexagon in the middle with the basic idea of making papers and publications open access, so people don't have to pay to get hold of them. And you've got the blue hexagon, the idea of making data available, and like the gray one, open source, making code available. But you could even be talking in some portions of the open science movement about having open notebooks, sort of making, as one's doing one's science, making that information available in real time to others. One can, discuss making the peer review process more open for others to see, what peer reviewers have said. One can incorporate citizen science in this and all kinds of things. So it can take a variety of forms. So just briefly, just to highlight, one could, as part of thinking about openness or transparency in science, focus on the publications. One could also be focusing on data, and also thinking about at what point in the project data should be made available, earlier or later. One can be thinking about making methods available. And of course, we're thinking about that a lot with these modeling discussions. In like medical research, there are even thoughts about pre-registering the methods. Should that be part of, before actually doing studies? Making computer code available, materials, making all results, like even negative ones that might not normally be published, that could be part of open science. Like I said, peer review, conflicts of interest, might be important, and values or value judgments. So that's kind of one way of coming to this discussion, realizing, maybe responsible science should be more open. And if we're going to do that, maybe being open about the values and value judgments underlying our work should be part of that. So that's one way to think about this. Philosophers and some folks, like I think Stephanie may have been coming from this angle a little bit, is to recognize, values play some really important roles in a lot of research, including especially this kind of health economics modeling that we're thinking about, because there are so many choices or judgments that need to be made. And Ian and Stephanie already talked extensively about this. But I'll just throw out this figure, sort of kind of an angle that I come to this. This is in a new book that's hot off the press that I'll show a picture of later in the talk. It's actually freely available for the next 2 weeks. So I'll go ahead and shamelessly advertise it. But so, you've got values involved on the left in steering science, sort of what direction your science takes, what projects are we going to prioritize and what questions. So this relates to modeling, what questions do we actually want to ask with these models? And then in the center, when we're actually doing the science and designing studies or creating models and structuring them and so on, choosing the categories for our analysis and deciding when we have enough evidence to draw conclusions. These all involves these choices, these judgments that often aren't determined by the available evidence. Choices involving using science, and at the top, also even just sort of managing the scientific process. So there are all these judgments, and I would just highlight very briefly, I want to be respectful of everybody's time, but just the array of different kinds of values, like Stephanie was talking about, that can play a role. You have like the individual values or goals that researchers bring to the table in terms of seeking career advancement and seeking funding and serving society, generating discoveries. Stephanie referred to epistemic values. Sometimes people will use the label of cognitive values. I won't bore you with the nitty-gritty reasons why people might use those different terms. Stephanie already talked about those. And then, of course, these ethical and social values that can affect these judgments in science. You might think about like collaborative values, sort of the values that we have in terms of being able to work together effectively, which could affect our scientific practice. And even when you're thinking about policymaking and modeling, you might think, in order for certain models to be especially useful, maybe they need to be kind of like standardized in certain ways or efficient in the ways we're able to use them or reproducible. So those can also be values that may not exactly be cognitive, may not exactly be ethical or social, but they also can play into these decisions. And so I think I'll move quickly over this slide because Stephanie has already done a nice job with it. But, there's all this philosophical literature suggesting, it's really hard to avoid making value-laden judgments in scientific practice. Even the terminology that's used, sort of what conceptual categories get used, questions about, is it appropriate, say, in medical research to use racial categories? It might be helpful sometimes for highlighting disparities, but it could also, sort of raise problematic connotations that somehow these categories are, deeply biologically significant. Even in economics, how we define concepts, things like unemployment, depending on how you define it, it can make it seem much more significant or less so. And, I just gave some examples from climate modeling here, but you all could apply this to health economics, and Ian, of course, already did so. But all these choices involved in designing and optimizing models, what you decide to focus on over what time period, and so on. And as has also been discussed, our standards of evidence, how much evidence do we want to demand before we are willing to draw a conclusion? These are all value-laden judgments in that they have an impact on our values, or, sort of values can play an implicit or explicit role in making them. And so here's the book that I will shamelessly advertise. You can go Google it and download a free copy if you want. And it is meant to provide a pretty accessible overview to this philosophical literature. And so in one section of the book, I lay out some of the different strategies that people have suggested for how do we manage all these value-laden judgments appropriately. And, one thought is, well, we just ought to choose the right values. We ought to engage in some sort of ethical analysis or some sort of political procedure. And then we make these judgments based on the best values. Another thought is, well, to avoid wishful thinking, like Stephanie was talking about, maybe we need to limit certain kinds of value influences where, some kinds just are problematic and you don't want some kinds of values to influence science. You might also think, well, this is why we need a really diverse scientific community to kind of help assess these different judgments and recognize them and help to critique them so, they can think them through. And you might say, again, tying into this project, maybe it's not enough just to have scientists discussing these judgments. Maybe you need some of the stakeholders, like the patients or, the publics at large, getting involved in assessing some of these choices. And here's where we get back to transparency. So some folks would say, no matter how you make these choices, some people probably aren't going to like it. And it's just responsible to allow people to recognize that certain scientific projects or models were performed based on certain kinds of value-laden choices. And so if people don't like those, it's important for them to understand that. So they're not depending on that kind of work that, is not going to support their, sorts of goals. And just for all these other techniques, if you want to engage with stakeholders effectively, maybe you need to be transparent about the values they may want to be thinking about. And if you want to have a good critical assessment in the scientific community, maybe you need a certain kind of transparency so people can recognize the issues they need to discuss. So that's part of how we get to this focus on transparency. And I'll just note that what motivated me to think about the taxonomy I'm about to lay out was realizing that transparency in general and about values gets kind of complicated. We've got these questions about, well, how much can we actually achieve this? We probably can't achieve perfect transparency. And do we want scientists to be trying to be transparent about these value judgments, or is that asking too much of them? Should we just ask them to be open about their data and their methods and their code? And is this really a job for the philosophers or the scientists or journalists, or who should be actually trying to make this transparency happen? And again, thinking about the dangers and the benefits and so on. So that's what kind of motivated me to do what I'm going to kind of lay out for you in the second part of the talk, which is to give this taxonomy. So this is in a paper that I published in the Canadian Journal of Philosophy a couple of years ago. And what I point out is there are several questions we might want to ask when we're thinking about trying to be transparent. So one is, well, why exactly are we wanting to do this? What's our purpose? And that can help us to think about, who we're trying to be transparent for, who's our audience. And that can help us think about, well, what's the content that's important to be transparent about? And then we need to think about, well, how we do this, over what time frame, how early in our research process should we be trying to be transparent? And what are the mechanisms for kind of making this information known and recognizable that might be implicit at first, that we might not recognize we need to discuss? And what venues do we make this information available in, and who does it? Who are the actors? And what are the kinds of dangers we need to be keeping in mind throughout this? So what I want to do in the following slides briefly is to just talk about each of these dimensions, if you will, and just give you a little flavor of the kind of variation there could be within these dimensions. Then you could extend this based on your own thinking. But in terms of the purposes, you might be thinking, very much from the perspective of the scientific community, like we want to achieve transparency so that we can reanalyze each other's results or make science more replicable and reproducible, and so help to kind of critically assess other scientists' work. But then you could come from more of a public perspective and say, well, we want to keep these experts accountable. They should be transparent so that they don't just run off and make a bunch of judgments that may not, reflect what we would do. And you might also think that this helps to promote autonomy, say for policymakers or citizens, so they can make decisions that accord with their values, and they're not appealing to models that surreptitiously are making value-laden judgments that conflict with their values. And you might think this would make science more trustworthy. So there can be somewhat different kinds of motivations for pursuing this kind of transparency. And then in terms of the audiences, as we've already discussed a little bit throughout these talks, it could be that you want the scientists themselves to kind of recognize, oh, wow, I'm making certain important choices here that have an impact on society. Or maybe you want other scientists to recognize, oh, the work that those modelers over there did rests on certain important assumptions. You might want the policymakers to understand, wow, these models actually do involve certain assumptions that are important to be aware of. Maybe the politicians, you want to be thinking about this. Maybe you want journalists to recognize some of these choices so they can do a more responsible job of talking about this in their work that the public is more likely to read. Maybe certain stakeholder groups, like certain patients groups, you want them to know about these choices, and perhaps other members of the public. So it's worth just thinking about particular initiatives. Who's our audience? And then, thinking about content. And here I'm assuming that we're at least somewhat focused on values because of the nature of this project. You might think about even other kinds of content if you weren't focusing on values. You might say, even if our focus is on values, it's still pretty important to be transparent about other kinds of information, like the data or the code or the methods that were used, so that then people can recognize how the choices with those methods were value-laden. Or you might say, I think the content we should be focusing on is the specific value judgments, like what questions were asked, or what terminology was employed, what standards of evidence here, or in the modeling context, Ian could really, and Stephanie could elaborate on a lot of these, value judgments themselves. Or is the focus on being transparent about the values or the factors that might have influenced those judgments? So do you want to know about people's funding sources? Do you want to know about the scientists' values or inclinations? So you just have a sense of, if they did face tricky choices, how might they have made them? Or are there regulations or standards that kind of force the modelers or the scientists to operate in certain ways? If this was a group, do we want information about their deliberations? Different kinds of things. Or some policymakers might say, I don't want to hear about all these nitty-gritty value judgments. Just give me the implications. Did this tend to overestimate the benefits or underestimate the benefits? Just give me the downstream effects of these choices you made. And then in terms of time frame, I'll just blast through this really quickly. You might try to be transparent really early in the research process, and that might be important if you're trying to get advice about how to end up making models, or later on, do you sort of, when you're publishing the information, say, you should be aware there were some important assumptions that we made here, or, we were funded by this particular organization when we did this. And then in terms of who is being transparent, I think it's worth keeping in mind, there might be this temptation to think, well, it's obviously the scientists who are doing the work and making the judgments that are, the actors that are being transparent. But, sometimes they might not have a good sense of all the value-laden judgments they made. Maybe it's the role of other scientists sometimes to look at these open access models and say, wow, there are some important judgments here in this work. Or sometimes scientific societies may play a role in evaluating important scientific work. Other scholars, folks like me, in philosophy or history or sociology of science, might be able to highlight important judgments. And again, for the general public, I would come back to the role of journalists, that your average person on the street may never watch a video about modeling. They may never look at this stuff in detail, but they might read a newspaper article or a blog post. And so they have a role in helping to achieve transparency that I think we should think about. Government agencies and NGOs, patient organizations, they may play a crucial role in passing on key information about values or value judgments in modeling or science that's relevant to their constituents, stakeholder groups, and so on. And then again, not to avoid boring you all, I do think it's important to think about the mechanisms for how we actually bring these value-laden judgments sort of to light, if you will, because they're not always so obvious. And so sometimes it may be discussions between researchers that actually sort of highlight these kinds of judgments, including sometimes citizen science projects, or where you have other community members involved in research. It could be discussions with policymakers where those doing important kinds of science or modeling actually sort of bring to light these judgments in discussions with the policymakers. Various sorts of public engagement events, I think, is very relevant probably to this group to think about. Community-based research efforts. Sometimes, stakeholder newsletters and reports can bring these kinds of judgments to light. And there have been suggestions for really significant research projects that you could even have these kinds of adversarial proceedings where you bring together people with experts with different views, and they kind of hash out their disagreements and clarify, what are the judgments underlying these disagreements. Anyway, you could have reports from advisory bodies as well. So again, very quickly, we often think about transparency happening in journal articles or editorials or commentaries, but there are a lot of other venues. In medical research, trial registries sometimes have important information. For the broader public, we need to think about, well, what role do newspaper articles and blogs and social media play in transparency? What role do public engagement events play? And like I said before, community-based research, and even science museums for reaching a broad swath of the public. It's interesting to think about, whether sometimes their exhibitions, a surprising number of people from the statistics I've heard, go to science museums, and that's a way to reach a broad audience, as well as people who are involved in particular NGOs or stakeholder groups, and so on. And we finally reached the last dimension of my taxonomy. Thank you all for hanging in there with me. It's important to think about the dangers as well, that this can take a lot of effort. And so we've got to decide what kind of transparency is actually worth it. This can take time. It can slow down researchers to, be transparent in certain ways about their data or their code or so on. And people can sometimes misuse the information. This has been a concern sometimes with, climate science, that, efforts to try to promote transparency can be used to harass these scientists, and people can become inappropriately skeptical if they hear, oh, this is all value laden, maybe we shouldn't trust what these scientists are saying. And so we need to, be aware of that too. And companies, when they're asked to make information about their science openly available, they can worry about releasing confidential business information. And in the medical context, sometimes important medical studies, involve private information that one has to be careful about releasing. So there are worries there. And it actually could also create a false sense of security or trust. You might have some pretty questionable pieces of science or modeling, and if people are, sort of open about certain choices they made, people might say, oh, this is really reliable. They're so open and honest, when maybe they shouldn't trust it so much. So those are things to keep in mind. So you don't need to worry about this big mess on the screen, but this just is the figure again from that article, just highlighting how many things there are to think about in terms of all these different kinds of purposes you could be trying to fulfill, the different kinds of contents that one could be trying to be transparent about, the different audiences you could be directing this information toward, and so on. So it just shows that transparency sounds nice. We're going to be transparent, but there's an awful lot involved in actually pursuing this. And so as you think about this, just very quickly in this last part of the talk, here are some of the things you might want to be thinking about in the further discussion going on tomorrow about the judgments that go into pursuing transparency. And as I noted at the beginning of the talk, I think there are three especially worth thinking about. One is, sort of, is transparency really worth pursuing in particular cases, given the kind of dangers? And what kinds of transparency should be pursued? What is our purpose? What is our audience? What kind of content are we trying to make known in particular contexts? And then how should we be framing the content that we actually do provide? So I'll just talk briefly about these 3 points, and then I'll be done. So in terms of the benefits versus the dangers, this all may not be as relevant when it comes to modeling, but as a philosopher, I tend to talk about conceptual issues and not data very often. But I actually have a little bit of data on this, where we asked a bunch of scientists, what are the barriers for you to sharing data, just on a 5-point Likert scale? And the highest sort of barrier was lack of time. So it's worth keeping that in mind when it comes to data, whether that's as relevant with some of these other kinds of, transparency and modeling choices is worth talking about. And then a lack of money, again, to pay people to help make data openly available in a meaningful way, difficulties formatting the information, and then worries about being scooped or misuse of information and so on. So I won't bore you with all that, but it is just worth keeping in mind that this takes effort and we need to think through, is it worth the effort in particular cases? Also, in the medical context, depending on what you're trying to be transparent about, it really is, it was a big issue in the United States over the past 3 years or so, worries about making patient medical information available. So under President Trump's administration, the Environmental Protection Agency said, we don't want to make decisions based on secret science. If we're going to make decisions based on scientific studies, the underlying data needs to be made available. And a lot of folks thought this was actually kind of a cynical effort to avoid using certain kinds of studies that showed, say, air pollution was harmful to people, because they knew that there was all this private medical information underlying the studies, and so it couldn't all be made publicly available. So we just need to keep in mind what we're actually being transparent about. With some of these modeling choices, I don't think it's as big a deal. All right, so just keep in mind the dangers. Then we have to think about, well, what kinds of transparency are we trying to pursue? And you can imagine from that chart I showed, with all those different dimensions and elements within them, you could have a zillion different kinds of transparency if you did all the permutations. I think they tend to clump together into maybe 3 or so kinds of transparency. And so I think one is, sort of transparency that's largely geared toward reproducibility and scientific efficiency. So that might be one way to think about transparency. Another kind is a little bit more directed toward policymakers, saying, how can we help them make good, responsible decisions and understand the values underlying the information they're provided with? And then a third kind of transparency might be, well, how do we make the general public or stakeholders, community members, aware of the information they ought to receive. And so it might be worth just thinking about, which of these are we focusing on, and how do we achieve what we're aiming for. So like if you're really trying to help the scientific community be more reproducible and efficient, well, then your audience is more other scientists. And then you may want to focus more on, making your code available, making your data and your methodological choices clear. And admittedly, there are dangers. It will maybe take some more time and money, and you have to be careful about privacy issues. But this is largely playing out maybe in the scientific literature and so on, and the scientists are kind of running the show. If you turn, though, more toward the goal of responsible policymaking, and your audience is policymakers, they may really care more just about the major implications of the value judgments that you made in your modeling choices. And so they may not want to get into a lot of the nitty-gritty details. And so one has to be aware of, well, how do we make this information available in a way that doesn't confuse them and cause misinterpretation and inappropriate skepticism? And maybe then, various kinds of advisory bodies that help to kind of, interpret scientific information for policymakers, maybe that becomes an important mechanism. And then maybe you need to bring in the role of stakeholders and NGOs to digest some of this information for policymakers and so on, and highlight important judgments. And then you could break this up into like particular stakeholder groups, like particular patients, and then like the broader public. But once you start thinking about publics, then once again, a lot of publics may not care as much about nitty-gritty judgments. They may want to just know about the most important value judgments in particular models that really matter to people or to the outcomes. And then once again, one needs to think about, sort of how is particular kind of transparency potentially going to cause confusion or inappropriate skepticism? And we really need to think about different media sources, I think, if we're actually trying to engage with broader publics, or, public engagement exercises of various sorts. And we really do need to think then also about journalism and science communication. Okay, and so you've survived. This is my last slide before the conclusion. And I just think it's also important to think about how this content is framed when one provides it. So say we're going to talk about value-laden judgments that went into a particular modeling exercise, especially if you're interacting with people who aren't experts, then you need to consider, do you just present like an array of options for how these judgments could be made, and you just sort of present them all as if they're equally good? Or do you kind of, filter the information a little bit and say, we chose to structure our model this way, or we think it would be wise to structure our model this way, but there are other ways it could be done. Here are some other possibilities. Or do you at least warn people that there are some really bad ways to do this that we think are poor? You're welcome to sort of consider them, but we wouldn't recommend them. Or do you say some options are just too dangerous to discuss or disclose, that they're just thoroughly problematic? So it's just worth noting, as you lay out different options, different values or value judgments, there are these choices to be made about how to lay that out. And as Ian really nicely highlighted, depending on your audience, you may need to provide different kinds of explanation. So it just is not useful to just like dump information out on people if people need explanations for that information to be meaningful. Otherwise, it's not really transparent in a meaningful way. And so if you want to read philosophical stuff on these value-laden choices about how you actually go about being transparent, I've got a piece down in the bottom that I published recently. So anyway, in conclusion, I think it's worth thinking about how we can get at these concerns from the open science movement, or starting from concerns about values and value judgments in science. And I tried to kind of just highlight all the dimensions that go into being transparent about this kind of information. And so as we move forward, it's worth thinking about what kinds of transparency are we actually after, and how do we want to pursue that, and how do we avoid the potential dangers, and how do we frame this information for folks? So I'll stop there, and happy to take any super quick questions.
Thank you so much, Kevin. What would be great is if folks do have questions for Kevin, if you could just pop those into the chat. We do want to make sure that we end on time and send you all on your way for lunch, because lunch is important. I want to give Sam about 2 minutes just to do a brief share back so you can see some of the magic that he's been making while we've been listening to all of these excellent talks. So Sam, are you ready?
Yes, let me just set up for 2 seconds. Here we go. And I'll do it in 1 minute so then everybody can get to their lunch. So beginning with Ian's talk, the highlights including that health economic evaluation asks these 3 questions. How much better is the new thing? How much more does it cost? And is that cost worth it? So looking at the subjectivity that are embedded in the models and how the organization evaluates the model quality, because it has this multi-million-dollar impact. And so he left us with these great questions around what is the role that the public does have? What should it be? Who could use the model and how could those models and information be more accessible? It's a great question about how much would you pay to extend the life or the quality of life of a stranger? I think that question is going to stay with me for quite a while. And then zoom over to Stephanie's talk, looking at how health economic models can best reflect values. And so what I've done here is just highlighted at the top the distinction between the scientific values and then the social and ethical values, but really that these ethical judgments occur throughout. And so the potential benefits, of course, of examining these questions are about involving patients and the public and enhancing the transparency in the economic health modeling that we're looking at. So also Stephanie left us with many questions around what is or what is not part of the research question. Our answers are social and ethical judgments that reflect our risk preferences, and our answers to these judgments are around how sure we need to be before we say something is true. And so again, highlighting potential benefits, concerns around the different types of models, looking at open source and then open access, and highlighting the work that she's doing around the peer models network. Okay, that was 2 minutes. Okay, and then just highlighting this last bit here from the last talk about the role of transparency with Kevin. I'm just going to highlight the last 3 questions that he left us with, which is to weigh the potential pros and cons, to be really clear around the audience and the exact kind of transparency, the type and the content that you're looking for, and then thinking about how to frame that information. So I think with that, it'll be best when we can send out the graphics for people to review in detail. And again, thank you to all of the speakers. Covered an amazing array today in the talks. I'm going to pass it back to Stephanie and to Trilby.
Thank you so much, Sam. Amazing. And as Sam said, we will be sharing a copy of the graphic recording with everyone who has joined us. And I know there were also, this was a question about the slides. So we'll just connect with the speakers and see if folks are comfortable sharing their slides, and there's a recording. So there's lots of ways to access the information. I do want to remind everyone that this is just part 1, and you all are going to join us hopefully for part 2 tomorrow, same time, same place, so same Zoom link, literally, at 10 a.m. Pacific time. And tomorrow's session will be 100% discussion-based and interactive, so really an opportunity for everyone to jump into the conversation. And so looking forward to seeing all of you then. Thank you again for joining us. We've popped into the chat a couple of links, excuse me, that were referenced in the talks today, and we'll make those available afterwards and again tomorrow as well. So thank you all. Enjoy the rest of your day, and we look forward to seeing you back here tomorrow.
Thanks, everyone.
Thanks all. See you tomorrow.
Shirley, would you like it if I pause the recording?
Yeah, actually, we can just stop it. That would be great. I can do that. Thank you for that.